Good morning, class. Today, our concept will be on elimination. A little background in elimination. Elimination is the excretion of waste products from the kidneys and the intestines. So let's talk about bowel. The bowel ability to expel feces with adequate hydration and intake, and the bladder's ability to void, that basically, kind of encompasses elimination. Okay, these processes, they must be in place before normal elimination will result. So normal elimination is defined as the formation, the passage, and excretion of waste products. So when it comes to the bowel, we have to have routine and voluntary passage of stool, preceded by that urge to defecate, okay, at regular intervals. And for the bladder, we have to have voluntary control, and the passage of greater than 30 to 50 cc's an hour of urine. And for a child, I know we're going to be dealing with pediatrics next semester, but that would be 1 to 2 cc's per kilogram per hour of urine. Okay, but if there are any deviations from normal of the bowel or the bladder's elimination, you're going to have negative consequences. And you're going to have to come up with corrections, interventions to correct the problem. So for today's lesson, we're going to focus only on the exemplars of diverticulitis and BPH, which is benign prostatic hypertrophy. Alrighty, so diverticulitis. Diverticulum, well, let's just kind of start off. So a diverticulum is a herniation or an outpouching of the bowel mucous membrane. It's caused by increased pressure within the colon and weakness in the bowel wall. So diverticulosis is a condition where you have multiple diverticula. Okay, they're present without the evidence of any inflammation. So a patient with diverticulosis is usually asymptomatic. Okay, so as on the slide, you see that diverticulitis, though, is the inflammation of the diverticula, okay, which, we call that those outpouchings. And the presence, of the multiple diverticula is called diverticulosis. So let's go back. Diverticulosis, you can have multiple diverticula, but diverticulosis is without inflammation. Diverticulitis is that inflammation of the diverticula. The majority occurs in the sigmoid colon, and it increases with age. So the incidence increases with age. So some people don't even know that they have diverticulosis because it develops gradually. However, only a small percentage of patients with diverticulosis even develop diverticulitis. It's caused by increased pressure and that herniation, so that weakness in the intestinal wall. And this is through a defect in the bowel wall, a low fiber diet. So that low fiber diet, that decreased fecal bulk, it caused the bowel wall to become larger, okay, and increases that pressure. So when you have a person with chronic constipation, that usually precedes the development of diverticulosis. Okay? When the diverticula become inflamed, when undigested food or bacteria gets trapped in those outpouchings, abscess can form and the diverticulum can rupture. Now, also, the diverticula can become inflamed by an inadequate lack of blood supply, nutrients from a poor diet. Okay. We talked about how severe constipation, also obesity, we talked about the poor diet, and we talked about how it develops gradually with age. So diverticulitis can be prevented by increasing dietary fiber to prevent constipation, which would prevent the onset of the diverticulosis. So, diverticulitis. So when diverticulitis occurs, the patient exhibits bowel changes. It kind of alternates between constipation and diarrhea. Diverticulitis, as a nurse, we're asking questions. Where's your pain? Where's your pain located? It's in the left lower quadrant. It could be severe, mild to severe. If perforation occurs, that pain is generalized. All of that, the content is being spilled out, I guess you can say, in the peritoneal cavity. Okay, so a person will develop peritonitis. Diverticulitis may cause a thickening of the intestinal walls as the condition worsens. Bleeding may occur, along with weakness, fever, fatigue, anemia because of the bleeding. A patient may guard their abdomen. They're not going to want you to touch their abdomen. They may have some rebound tenderness. If an abscess develops, the diverticulum can rupture, like we said before, leading to peritonitis. Diverticulitis can be acute, kind of similar to an appendicitis, or chronic because of the severe constipation, the pain, the distension, and flatulence. So that flatulence, so that gas will increase the pressure of the intralumen, of the colon. Okay. Also, while we're collecting data, and we kind of talked about this, a personal, a patient will complain of fever, chills, guarding of the abdomen. They may have some abdominal rigidity. They may have tachycardia. Like we said before, when that diverticula ruptures, it will cause peritonitis. When that fecal material kind of spills into that peritoneal cavity. Also, a patient will complain of occasional rectal bleeding, diarrhea, and then, on blood work, they'll have an elevated white blood cell count. Now, diverticular disease is diagnosed with a barium enema. However, it is contraindicated when diverticulitis is present because of the risk of rupturing. Okay, so you may have, if diverticulitis is there, they're not sure if an abscess is there. They give the barium enema. The barium enema increases that pressure on the walls of the colon, and then it can cause a rupture. And then, like we said, all of that fecal material is in the peritoneal cavity, causing peritonitis. But it also, diverticulitis can be confirmed with a sigmoidoscopy or a colonoscopy, where they'll be able to visually see that diverticula in the areas of inflammation. As you can see, they also can diagnose it with a CAT scan, an ultrasound, If an abscess is suspected in the beginning, they're probably going to go on ahead and get a CAT scan. We talked about a barium enema, a stool specimen will most likely it will show occult blood. They can even do an abdominal x-ray that can identify a perforated colon. Alrighty, so how do we manage this? What do we do? Diverticulosis, let's go to losis, is managed by preventing constipation. However, with acute diverticulitis, the patient may have to be hospitalized, for IV antibiotics and for pain control. They may place a nasogastric tube. They may be administered IV fluids. They're going to tell them, nothing by mouth. They're going to put them on NPO status. And they may be given something for pain control. Okay? Something for nausea. Because they'll probably, have, symptoms of nausea and vomiting. They may have fever. Okay? And they'll have inflammation. So when a person has acute diverticulitis, you want to place them on NPO initially, bowel rest. As the slide talks, it says high fiber diet, especially, now this is after the NPO status, okay? And now they're able to kind of progress. So you start off NPO. Then, the doctor says, okay, you're getting better, nothing's perforated, let's start you back on some food. So we'll start you off on a high fiber diet. Fruits, vegetables, okay? You're adding bran to your foods every day to give that bulk. All of these things are trying to prevent the constipation that precedes the diverticulosis that can precede diverticulitis. Okay, so we have to start with diet first. Now, a long time ago they used to talk about how, don't eat any seeds, don't eat strawberries, don't eat popcorn, don't eat anything that can get caught in those outpouchings. But, they never really, came to any real conclusion that these things actually cause diverticulitis. You also want to encourage your patient to drink 6 to 8 glasses of fluid a day, unless it's contraindicated. So if you have a patient with CHF, you're going to have to, make sure with the cardiologist, how much fluid can they actually take. You don't want to say, drink, 2 and 3 liters of fluid a day. So, that's for you, everyone else other than those people that have chronic conditions that would contraindicate that. You also, when we talk about fiber, you want to kind of start slow, because too much fiber too fast can cause excess gas. And we talked about the gas, increasing the pressure on that, the lumen of the colon. And it can cause cramping, so they're going to have some discomfort. So you want to educate them on how to change their diet, but you also want to have them started slowly. If a patient is overweight, you want them to lose weight. But we talked about when it's in the acute phase before, they may have some bleeding. So you're going to have to look for any signs of bleeding. So you're going to, you should check. If they give you a stool, check for occult blood. Whether or not perforation occurs, when you have a patient that comes to your unit, you're going to want you want to prepare them for possible surgical resection. So what they'll do is that they'll either cut off the diseased portion of the colon and then take one end and then take another end and they hook them together, the good part, or they'll give them a temporary colostomy. And this is done, while the inflammation's getting better and, as they progress, it may be, 2 to 3 months, and then they'll reverse it. They'll connect those healed parts of the colon together, and then they'll close that colostomy. So, well, like it says in the slides, as a nurse, patient comes to your floor, you want to prepare for surgical intervention. Colon resection is done in 25% of the cases of diverticulitis, especially if it's ruptured, if the diverticula ruptured. What they do sometimes is that a person comes in and they're not quite sure. They do a CAT scan. They don't know if they want to actually do surgical intervention. What do we do? They'll probably go in and do a laparoscopic surgery. They go in, kind of see what's going on, and then if they have to actually do more surgery, then they will at that time, or if they can take care of it laparoscopically, they will. And they found that this kind of helps with decreasing morbidity and mortality associated with the emergency that can happen, especially if the colon is perforated. Medication therapy, as you can see on the slide, antibiotics, broad spectrum. So you may see somebody getting ciprofloxacin. Bactrim, or another name for Bactrim, would be metronidazole. Metronidazole is Flagyl. So you'll see ciprofloxacin, you'll see Flagyl or metronidazole or Bactrim. And Bactrim is a sulfur drug. So you will see the three of these if someone comes in with diverticulitis. They'll give, like we talked about before, so now you have antibiotics. They'll give them something for pain, stool softeners. But laxatives and enemas are contraindicated because, of course, you have an enema, you're filling up the colon with that extra fluid, and the fluid, can increase the pressure on the colon, so you don't want that. Okay, so that's why those are contraindicated. Then also don't forget antipyretics for fever. You want to reinforce teaching. We talked about the fiber, fiber foods. You want to educate them on side effects of medicines, complications of diverticulitis. You don't want them to strain or increase any kind of pressure, so no lifting, no straining, no bending during this time, okay? And when you look at diverticulitis, we all have to come up with nursing diagnoses. So you can say acute pain, related to the inflammatory process. Okay, so what would you do? You would have them, you would ask them about pain. You may help them with diversion activities or things like that to try to help them with the pain that they're experiencing. Another one would be risk of deficient fluid volume. That would be, the diarrhea. We talked about it alternates the diarrhea and the constipation. So with that, you would, know that you're going to be administering IV fluids, eyes and nose, things of that nature. Also on Canvas, there are articles, and the articles are very good. They really explain diverticulitis very well. I would recommend y'all to actually read those articles and get a better understanding of that content. So we're going to move on to BPH, or benign prostatic hypertrophy or hyperplasia. Let's see. So BPH is the enlargement of the prostate gland. Now it's from non-cancerous hyperplasia, which is the increased number of cells of the prostate, or hypertrophy, which is the increase in size of the cells. But if it's the increased number or the increased size, the outcome is still the same. That gland is going to get bigger, and it's going to block that urine flow. So the prostate gland, which is part of a man's reproductive system, slowly gets larger as he gets older. So around 40 to 50, it starts getting bigger, but usually asymptomatic until he's about 60 years old. Okay, and as you see on the picture, as it grows, it begins to compress the urethra. Okay, and so it compresses the urethra, and that urine starts backing up in the bladder. And then, if it compresses it so much, it's going to totally obstruct the urine. It's going to totally obstruct, so you're not going to have any, you're going to have a urinary obstruction, okay? So that outflow of urine, it's not happening. That urinary stream, that's why one thing that you would ask your patient, you would say, has your stream changed? Is it getting, we usually say weaker. So is that stream getting weaker? Was it forceful and now it's just kind of weaker and weaker? Is voiding becoming more difficult? Talks about how, a pouch is formed in the bladder. The urine kind of stays stagnant. It can cause hydronephrosis. Now what hydronephrosis is the accumulation of the urine in that renal pelvis. Because think about it. The gland has stopped the outflow of urine, so everything starts to back up. And when obstruction is complete, you'll have acute urinary retention. Now, one thing I want to say about BPH is that this is not cancer. Okay? And if a man develops BPH, it does not increase their chances of developing cancer. Okay? But it can cause a bunch of other issues. So, man will have urinary tract infections, bladder, or even kidney damage. Now, the causes are unknown, other than normal aging. But some sources believe that it could be due to decreased testosterone and increased estrogen. Okay? The prostate cells increase in size and in number because of this increase in estrogen levels. The testosterone changes, and to other things that we're not really going to talk about. But because of these hormonal changes, that prostate gets bigger. Okay? And like we said, it grows and it decreases the diameter of the urethra. They say incident, we talked about usually over 50 years. They say related to smoking. Other sources say maybe even excessive alcohol intake, high fiber diet, ethnic background. But they don't really know. When you talk to a male patient, you want to ask them, like we said before, you have any problems urinating? Any difficulty urinating? And there's no real cure or prevention. Let's say prevention. There's no real prevention for BPH other than castration. Okay, and so we're not going to be doing that. So if a man lives long enough, past 80, he'll probably have problems. When he's in his 90s to 100, he will most likely have BPH. So, looking at signs and symptoms. So if you have BPH, you probably have some of these things on the screen. And they're all related, to the lower urinary tract. So you'll have dysuria, frequency, nocturia, so you're waking up at night to urinate, urgency, you're trying to get there, and you can't get there quick enough. Retention, you're straining, you just can't push it out. Hesitancy, you want to go, you get there, and then it just only a small part comes out. You have the burning, decreased force of stream, the dribbling. A man may say that they've had some incontinence, some bedwetting. They just, their bladder's just not emptying all the way. So we'll see, as nurses, man has urinary tract infection. He has acute urinary retention. He'll have hematuria, so you're going to see blood in the urine. When we do diagnostic testing, he's going to have an enlarged prostate. And we've said this before, so the prostate enlarges, you'll have your urethra becomes obstructed. If it's left untreated, you'll have bladder outlet obstruction. We talked about it. We talked about acute urinary retention. We talked about the bladder infections. They may even have bladder stones. We talked about the hydronephrosis. And then you will have post-renal acute kidney injury because, we have to, like we said in the beginning, you have to have a normal, everything has to work. And it has to work routinely. And when things aren't working or if things are obstructed or we have problems, it will cause, other issues, other complications. And with this and with BPH, if we don't correct it or that man does not go and get that catheter that we're going to be talking about in a little bit, or correct that urinary retention, it will cause kidney injury. So diagnostic tests, diagnosis is kind of made based on the symptoms. A man come in and he says his stream has changed. Okay, I'm having all of these symptoms, hesitancy, nocturia, so it's kind of like someone comes in and you're like, hey, this really sounds like BPH. So patient history, like the side says, assessment. Okay, someone may come in and their temperature could be elevated. If his temperature is elevated, hey, maybe does he have a urinary tract infection? Secondary to, we said that the urine just kind of stays, you have urinary stasis. It just kind of sits. They may have a distended abdomen, bladder distension, due to retention. Okay, and we talked about the UTI that increases the risk for a UTI. A provider may do a digital rectal exam, and that would, they would be checking for the size and the shape of the prostate. Urine culture, urinalysis. We're looking to see, infection. The BUN, we're trying to figure out kidney function. The BPH has this backup. The bladder outlet obstruction has this now caused acute kidney injury. So we need to check a BUN. We need to check a CBC, look at infection. A creatinine will also check kidney function. An ultrasound will let us examine the prostate. Some other things is a PSA. which is a prostate specific antigen that can tell a patient, or a provider, is this BPH or is this cancer? Okay, because cancer can also enlarge the prostate. They may do a bladder scan, a post-void residual. So the male patient goes and he urinates, and then after you scan the bladder to see how much urine is left. Okay, and then they may just go on ahead and do a biopsy of the prostate also to make sure that it's not cancer. So they did that PSA, and they're like, it's elevated. We don't know. Let's do a biopsy just to make sure that this is just the increased size or the number of cells and not actually cancer. For treatment, okay, looking at the screen, it's telling you, a few things that can be done. But, if a patient has no symptoms or mild symptoms, the most, current medical approach, we just kind of wait. We just kind of watch and wait. The healthcare provider, will see if the symptoms increase, to see if the urethra becomes or is becoming obstructed. So these treatments may be an indwelling catheter, okay, intermittent, self-catheter, encourage fluid intake, antibiotics if needed, if they have a bladder infection of some kind. Also, when it comes to conservative treatment, they may use medication, like to relax the smooth muscles of the prostate, or the bladder neck. They may also use something to try to block the male hormone to prevent or shrink the growth of the prostate. So, we have to think about, certain medications, they're treated for high blood pressure. So you're going to have to make sure that the medicine that we're using for high blood pressure isn't going to, lower their blood pressure, and cause hypotension. So the most common medication to block that male hormone is Proscar, or another name is finasteride. It helps shrink the prostate. Okay, we talked about the testosterone and the estrogen, so it stops that testosterone from converting to DHT. You don't have to know that, but we talked about how the testosterone, as a male gets older, it gets less, and the estrogen increases. But that testosterone, that prostate still soaks up that testosterone, and it can grow. That prostate grows. So this Proscar prevents that conversion from happening, so we can try to shrink it. And then also a medication like Flomax helps to relax the bladder. Also, we're looking at the suprapubic cystotomy and insertion of a catheter for long-term drainage. So that would be something else that can be used as well. Also, another treatment, they call it TURP, which is a transurethral resection of the prostate. Okay, as you can see, it's an instrument passed through the urethra to the prostate. So the patient is anesthetized, and the surgery is performed. The resectoscope, that's what they call it, is inserted into the urethra, and the prostate gland is kind of chipped away, little piece at a time. As you can see, we don't have that picture. Oh boy. There's a picture there. I'm going to see if I can get this picture for y'all so y'all can see it. But it chips away a piece at a time. Okay, and then the instrument also cauterizes it or microwaves the pieces to decrease the amount of bleeding during surgery. And then these chips of the prostate is flushed out by irrigation solution and sent to the laboratory, so they want to make sure that, it's not cancer. Now the prostate gland isn't completely removed. It's not. It's just kind of peeled away. And the prostate tissue that remains can come back and cause obstruction again at a later time. So patients have to be reminded, hey, you got to go in and get your yearly prostate exams. So following, a Foley catheter is put in place with about 30 or 60 cc's of sterile water inflated in the balloon. And this balloon, it's overfilled because you want to make sure that it stays in place. Okay? And you want to make sure that that pressure of the balloon to the prostate area, make sure that it also helps with stopping of bleeding. The catheter may stay in place about 3 to 5 days to help drain the bladder, and it's going to be irrigated, and we're going to talk about that in a second. It's going to be irrigated continuously for the first 24 hours to you want to get rid of those clots and those chips of that prostate that they kind of chipped off. You want to make sure that you want that catheter to remain patent. Okay, and the Foley catheter is going to be removed after the danger of hemorrhaging has passed. All right, so we want to educate the patient about the procedure, that they're going to be under anesthesia. We want to educate them about, when they're recovering, they're going to have continuous bladder irrigation. This is going to prevent clotting, like I said, because you don't want the clots to obstruct the urinary output. Okay, when they go home, they're probably going to have an indwelling catheter. So you want to make sure that this catheter is frequently, it has frequent continuous flow. You want to make sure, because that's the way of getting out all of those blood clots and all of those chips. Now, after surgery, the biggest thing is you need to be worried about bladder spasms. And then prior to surgery, you want to tell them to avoid any kind of NSAID, because this will reduce the clotting time. Let's see. Another thing that you're going to have to do, post-op, is to look at the urine for bleeding. Every single time a person urinates, you empty out the catheter bag. You need to look at the urine. You want to make sure that there's less blood with each void. So let's go over complications. The complications are clot formation, bladder spasms, and infection. Okay? Less common complications, but they occur: urinary incontinence, hemorrhage, and erectile dysfunction. So let's talk about bladder irrigation. Continuous bladder irrigation. Now, you want to, we briefly talked about it a few minutes ago, but we want to maintain that rate of that irrigation fluid. You want to make sure you want to keep the output of the urine that's being irrigated. You want it to be light pink or colorless. You want to assess for urinary output every 1 to 2 hours for color, consistency of amount, the presence of any clots. You want to assess for bladder spasms. You want to assess for pain. If you have any bladder distension resulting from an output obstruction, so just say, you're irrigating, but you're not really washing it, and a clot or those chips kind of block the outflow, that will increase the risk of bleeding because the bladder is stretching. Now it's stretching, and it's expanding the tissue. Okay, you want to make sure that you calculate the difference in the irrigation fluid and the patient's actual urinary output. Okay, when you do your eyes and nose, how much was put in, in the irrigation solution? How much is in the Foley bag? You want to subtract subtract the two. You want to make sure, okay, how much of this is actual urine? Okay. Another thing that you want to assess after surgery is called TERP syndrome. Okay, this is, you're giving that patient all those fluids. So the fluid volume excess, it causes hypernatremia. So what's happening is that the fluids that we're giving them to kind of help irrigate, the bladder after this TERP is absorbed by the body. It's absorbed after surgery. And so because of this absorption of all of these fluids, that patient will develop hypernatremia. Their blood count will go down because now they have too much fluid. Their blood pressure will go up because they've assumed all of this fluid. They'll develop bradycardia, nausea, confusion. If any of these happens, you need to notify that surgeon or healthcare provider immediately, because if left untreated, a person can develop dysrhythmias and or seizures. Okay, so that's big. Another surgery, as you can see on the screen, is a suprapubic transvesical prostatectomy. Let's see, low incision. Let's see what I put in here. Where it says 2 drainage tubes are inserted. You got the cystotomy tube and the Foley catheter. You want to make sure that you're assessing the urine output from both of those, okay? And you want to, with surgery, you want to make sure they have that low incision over the bladder. You want to look at that abdominal dressing for any urinary drainage and change frequently. And that's because, urine irritates the skin. You want to make sure that you change that dressing frequently. The retropubic prostatectomy, this is a low abdominal incision. The bladder is not entered. The biggest thing with this is after surgery, you want to assess the abdomen. You want to assess that incision. You want to assess that dressing for any presence of urine or purulent drainage. Because if present, you need to report that to the surgeon, because the bladder wasn't entered. So if you have urine on your dressing, that means that they nicked the bladder, and you need to let the surgeon know that ASAP. Okay? Perineal prostatectomy. The gland is removed through the incision. So the big thing with this is you want to assess for drainage and any signs and symptoms of infection. After this surgery, we want to make sure that we don't do any kind of rectal temperatures or enemas, because that can precipitate or start bleeding. You want to tell the patient about sitz baths, keeping the area clean, because the biggest thing is that they've gone in the perineal area, and you want to teach the patient to make sure that they constantly keep that area clean because of the proximity between the incision in the perineal area and the anus. Because of that close proximity, that wound is prone to infections. Okay? Other treatments. We talked about the finasteride, the Proscar. We talked about, they have the transcystoscopic urethroplasty, the transurethral incision at the bladder neck. So basically with the TUIP, that transurethral incision, the biggest thing with that is that the gland is split to reduce any pressure on the urethra. They talk about microwaves. Now, the transurethral microwave therapy, what that is that, it's minimally invasive. They put an electrode, they pass it through the urethra into the prostate. And that heat destroys the tissues and causes the gland to shrink, and the ease of urine flow is restored. And a stent, the prostatic stent, the implantation of the intraurethral prostatic stent, they're put in to keep that urethra open. Tissue growth on the metallic stent will anchor it in place. But if they use a plastic one, it needs to be changed. So they got to go in and change it every 4 to 6 weeks. Now that sounds like an inconvenience. However, the gentleman may be at a position to where he can't take the medications for whatever reason, and he may not be a surgical candidate. So these are other options that can be used for those kinds of patients. So as nurses, what do we do? Okay, so nursing interventions. On admission, we want to complete an assessment. We want to ask, we talked about aging, what are their chances of infection, them being anxious. They don't know if it's cancer, what's going on with me. We want to make sure that we're also looking at other problems, diabetes, cardiovascular issues, hearing and sight. Are they able to understand what we're saying? Are they able to read any information that we have to give? Are they having any GI problems as well? You look at constipation. Think about it. Your constipation is squishes on the bladder as well. So that can be another issue. If, you want to try to teach them, drink lots of fluids unless it's contraindicated, like we said before. Monitor the eye and nose. Teaching, want to teach the patient about an indwelling catheter, but expect to insert a catheter. Other nursing interventions, you may have to provide pre-op care, post-op care, making sure that catheter is draining, making sure the irrigation is going, look for clots, make sure that it's not obstructed. We want to make sure that we change the dressing when it becomes wet. But that first dressing, remember, and y'all may not know this, but it has to be, usually it's changed by the physician, the first one. Now, if, that can change, that's only in an emergent situation, but we'll talk about that in peri-op. Make sure you monitor the vital signs. You're really looking for, elevated temperature. Hematuria is expected, but you're not supposed to be seeing like bright red blood or lots of clots, okay? And no straining, okay? We want to avoid straining because that pressure on the tissue can cause bleeding. Let's see, other nursing interventions. We want to observe for spasms, pain medicine. We talked about eyes and nose. We talked about the sit-stats, for the perineal prostatectomy. And we want to make sure that we provide any kind of discharge instructions, especially with the patient that's going home with an indwelling catheter. And basically that's about it. Like I said, after diverticulitis, you have an article that talks about BPH. I would read it. It kind of helps put everything together. It helps you to be able to understand what's going on. I think there are two very good articles that are on Canvas. So that is it with the lecture today. It's a little bit different. It is it's a little shorter because I was able to kind of go through it, but everything is there. Good luck on your test. Have a good day.